As we all know, in the immediate post-op, you may have either one or two clinical positions in which you may have, as we all expect, a normal dry incision or a draining incision. Certainly, if the draining incision continues for a few days, we are all worried about infection, and this undoubtedly needs further studies. But the other condition, which is probably the most normal one, is that we have a normal dry incision in the second, third, and fourth post-operative day, and however the patient develops a fever of over 36.8 or 37 degrees Celsius. And in this case, we and all clinicians will be thinking whether we are dealing with an infection or not, and what is the importance of this fever in the immediate post-op. So certainly it is a worrying finding in the immediate post-op, and we should know and understand the causes of fever and what is the correlation, the eventual correlation to prosthetic joint infection, and if then, what studies or what should be done to rule out or rule in an infection, and be very cautious not to unnecessarily prolong the admission. There is some literature on the aspect, and this is one of the classics. In 1999, Shaw and Chung from Washington in the US demonstrated that fever was due to an inflammatory response and the tissue damage ensuing after the operation. In another paper from Hopkins in 2003, Brett and Alter showed that they measured the samples of blood and of drainage fluids, and they showed an increase of endogenous pyrogens, namely interleukins and cytokines, which were described as the source of fever in the immediate post-op. And again, another paper from Gwynn at Louisiana and Tulane, they showed us and demonstrated that after total knee, but this is also maybe for total hips, that the higher and or prolonged that the fever was, the most likely it was that we could indeed find the cause. So in our case, we studied 4 consecutive months. In 2010, this has been published already in Argentina, in which we looked at 190 consecutive arthroplasties, 126 females and half males, 64, with a wide spread of average age from young people with dysplasia to 91 years old. And of course, all patients were operated on a laminar flow operating room, and as you see, antibiotics for 24 hours, DVT prophylaxis for 2 to 3 weeks. And certainly what we did was analyze the thermic curve. And the only case in which we gave additional antibiotic prophylaxis was in males, if we had to insert an indwelling bladder catheter, since it is known that manipulation on the urinary tract may cause bacteremia. The inclusion criteria for this subset of patients was that we needed a minimum 1-year clinical and X-ray follow-up, and of course that they had no other active infection. And the exclusion criteria was that in 33 we had incomplete data, and 6 of them were patients that had had an infection and the operation was a revision after a spacer, so they were excluded because there was a previous infection. This left us with a cohort of 151 joint arthroplasties. As you see, 100 hips and 51 knees, and you see the distribution between primaries and revisions. Again, none of these were revisions post-sepsis. And what were the results? The results were that in 39 out of 151 patients, which is exactly 25%, they had fever. And the percentage of fever in the post-op was slightly higher in knees, as you can see, than in hips, although this was not statistically significant. The fever with a cause in 39 cases was found in 14, and we understood and arrived to the conclusion that the fever was due to a blood transfusion reaction in 10 out of 14 cases. 2 patients had cellulitis at the site of arm venipuncture, 1 urinary tract infection, which is a very well-known cause of fever in the post-op, and 1 patient had a paralytic ileus. And that left us, as you see in the last line, with 25 cases out of 39 in which post-op fever was of unknown cause. And what was the distribution of this fever in these 25 patients? As you see, there were 4 patients out of 25 that had fever in the first post-operative day, but 21 of them had fever in the second and 16 in the third post-operative day. And of course, since a few patients had fever in more than 1 day, the total number does not add to 25. And if we distribute this between hips in red and knees in green, you see the distribution is almost exactly the same, having most patients very rarely fever in the first night, the first evening after the operation. Most of them had fever in the second and third day post-op, and then it gradually wanes away. So the result in these 39 patients after minimum 1 year follow-up in these patients with fever was that there was no cases with deep prosthetic joint infection. There were 2 superficial infections treated with local wound care, and 1 patient had a post-op traumatic lesion of the knee extensor mechanism that needed surgical repair. So in the discussion, we can and we should know and understand that the fever in the immediate postoperative period is not related to age, to gender, to operative time, or to the type of anesthesia, whereas it may be related to blood transfusion, be it autotransfusion or bank blood. It may be related also to urinary tract infections, to pulmonary atelectasis, to inflammation at the venipuncture site. It may be drug-induced fever, and there are several other rare but somehow appearing possibilities. So in conclusion, postoperative fever in the first 4 days is a physiologic response to tissue damage. If you have a patient with a dry wound and absence of clinical findings, you should not perform any additional tests that will be costly and that will certainly prolong admission. So you are okay if you have a patient in good clinical condition with a good dry wound, that you can discharge him with a fever up to 38.5% degrees, because it would certainly go away at home without any additional medication of measures. Thank you for your attention.